We're now going to talk about some of the abnormalities of the eye, some anatomic abnormalities. The first thing we're going to talk about is congenital abnormalities like colobomas, which we already mentioned in the first chapter. Coloboma can happen in the eyelid. It's probably one of the most common manifestations of colobomas will be the eyelid. It can also occur in the iris and all the way down to the retina. Epicanthal folds are a common finding, and that's that little fold that goes by the eye on the inside part towards the nasal aspect. The epicanthal folds can sometimes give an impression of pseudostrabismus, which we'll discuss shortly. And ptosis is something that's commonly seen. Sometimes we've already discussed Horner syndrome with ptosis. Some patients are just born with ptosis of one or both eyelids. Typically, you don't need to do anything about the ptosis. It's just that droopy eyelid. Sometimes surgery is recommended if the droopiness is severe enough that it actually is covering most of the eye and the patient can't see well. Then you worry about developing amblyopia. In that case, surgery would be recommended. Otherwise, it's only for cosmetic purposes. Infections of the eyelid itself include the hordeolum, which is just your basic stye. Fancy term, hordeolum. Most people just call it the stye. It's usually a staphylococcal infection of the ciliary follicle along the lid margin. So if they ask you, think of staph. And that can be treated with some topical antibiotics. The chalazion is actually an inflammatory response. It's a lipogranuloma of the meibomian glands. It is very difficult to distinguish it sometimes from a hordeolum. If the chalazion doesn't get any better with antibiotic treatment, you aren't really discussing the hordeolum, you're actually treating a chalazion, and the antibiotics won't help, and it really needs to be surgically scraped out, and these do recur. Here you have a coloboma of the iris, not so much of the lid. It can occur with the lid, but also any layer of the eye. And this is, again, called the latchkey eye, just a defect in the iris in this particular case. The arrow over here is pointing to the epicanthal fold. It's like an exaggerated layer, and it can cause or give the impression of pseudostrabismus. Prominent epicanthal folds are found in certain syndromes, such as trisomy 21. And here we have a child with ptosis. You can see that this eyelid is normally elevated, whereas this one is droopy. This one is not causing any problems, probably does not need to have anything done. Other abnormalities, this is not really an abnormality so much as this is an infestation, and this is lice. These are little nits that you see on the eyelids, and the best way to remove these is to just use a little bit of Vaseline on the eyelid, and they're on the lashes, and you just kind of pull them off. This is the hordeolum, so this is the stye. This will just require some warm compresses and anti-staphylococcal eye ointment. And this down here is the chalazion. You can see that it is a little bit different, but sometimes it is difficult to distinguish from the hordeolum. The chalazion, when you open that, the ophthalmologist would open that and scrape it out. It has a tapioca pudding type consistency to it in appearance too. We've already mentioned aniridia in the first chapter, and we mentioned coloboma of different layers of the eye, so we're not going to discuss the coloboma anymore. The aniridia, remember, absence of the iris, and also remember to make that association of aniridia with hemihypertrophy and Wilms tumor. Leukocoria is a white reflex. The normal light reflex should be red or tan or orangish. If they mention a white reflex or they use the word leukocoria, right away you should think of a retinoblastoma. That's the first thing you should think of on the exam if they mention leukocoria. A cataract can cause a sort of whitish reflex, but actually what's happening there is that the light is not going through to the retina. Also, other causes of leukocoria or that white reflex would be retinopathy of prematurity or a retinal detachment. But for the exam, think of a retinoblastoma first and foremost. Here is a child with a white reflex, and this is leukocoria right here, this area right here, and that is most likely going to be a retinoblastoma. Cataracts in the children, the majority of them are going to be congenital. They can sometimes disappear, the cataracts that are associated with prematurity. When they discuss cataracts on the exam, if they're discussing congenital cataracts, the two things that should come to mind right away is going to be rubella, congenital rubella syndrome, and the second one is going to be galactosemia, and they will give you findings in the stem of the question to lead you one way or the other. There are some chromosomal anomalies that course with cataracts, but for exam purposes, the two main things you should think of right away, congenital cataracts, is going to be rubella and galactosemia. And here we have a child with cataracts bilaterally. It's this opacity that you see there, and so typically you're not going to really get a light reflex because the light is being impeded from hitting the retina and bouncing back. Abnormalities of the lens, they may mention ectopia lentis or a dislocated lens. And if you hear that, and they will probably describe a couple other things in the patient, but when they start talking about lens dislocation, start thinking right away of Marfan's. Trauma can cause a dislocation, so if you're reading the test question, they will mention some kind of trauma if they want you to think along those lines. If they want you to think along the lines of Marfan's, they will give you a patient that wears thick glasses, has a dislocated lens, and they will give you findings of Marfan's like arachnodactyly, tall stature, things like that. So put those together. Other systemic causes include homocystinuria, which we've reviewed previously, Ehlers-Danlos syndrome, because remember again it's a problem with connective tissue, and we've discussed that previously also. This is something that's also common on the exam, is looking at eye alignment. So we're going to discuss strabismus, pseudostrabismus, and amblyopia. Strabismus is a misalignment of the eyes. It comes from an abnormal innervation, and what happens is that muscle then gets kind of tight from the innervation. The muscle will pull the eye in one particular direction. Any of the extraocular muscles can do this, so the strabismus can be in a variety of directions. It's not just necessarily cross-eyed, but the eye can be in any particular orientation. It's very important that when you examine the child or when you read the test question, they will mention that the patient has normal extraocular movements. It's at rest that you see that the eyeball is deviated in a particular direction. It's also important to know these particular tests, what are known as the Hirschberg test and the cover test. They like to ask questions and give a name of something like so-and-so's sign or so-and-so's gait, just to know if you know what they're talking about. So the Hirschberg test is basically you will shine a light and see where it bounces off on the eyes. And I'll show you a picture momentarily. Normally, if the eyes are normally aligned, the light will bounce off the center of the eye, the center of the pupil, and you can see this little reflection right in the center of the pupil. If the eye is misaligned, then you will see on that particular eye that it's bouncing off a different part of the eye, such as the iris, for example. You then do the cover test. The cover test helps you to diagnose amblyopia, or what we commonly call lazy eye. The cover test is you cover the good eye, and then you watch the misaligned eye slide into position and fixate on you. So that would tell you that the patient has amblyopia. Pseudostrabismus is seen typically in the neonate and in a young infant. Remember that I said that the binocular vision doesn't occur until about 4 months of age, so that's one thing developmentally. And secondly, just the facial features of the infant contribute to this appearance of pseudostrabismus. It looks like the eyes are crossed, but they're not. What contributes to this is that they have a wide nasal bridge and they have these epicanthal folds, and that makes it look like the eyes are somewhat crossed. If you do a Hirschberg test, you'll see that they're aligned properly. So there's really no treatment for pseudostrabismus. The treatment of strabismus is going to be putting them in glasses, and eventually they may need surgery. What they do is they reattach the muscle to a different part of the eye, so that compensates for the misalignment. Amblyopia is the lazy eye. What happens is that one of the eyes gets an unclear image or is deprived. So for example, strabismus can lead to amblyopia. If one of the eyes is misaligned, that'll be an abnormal image, and the brain kind of shuts that off and doesn't pay attention to it anymore. So then the eye gets kind of lazy. It is usually treated by patching the good eye. So once you make the diagnosis of amblyopia, it's important to patch the good eye and force the bad eye to work. you have to be very careful. The ophthalmologist will follow the patient, because if you patch the good eye for too long, it'll become lazy because of deprivation. Here's a beautiful example of some exotropia. So this patient has strabismus. Remember, strabismus is not necessarily cross-eyed, but it's an abnormal innervation or misalignment. And here, if you look right here in this eye, right there is where the light is bouncing off on the Hirschberg test. When you go over to the other eye, since the eye is misaligned, it's not bouncing off the center of the pupil because the eye is moved over. It's bouncing off there. And so that's why that's an abnormal Hirschberg test. Diseases of the conjunctiva, the most important one you're going to need to remember is ophthalmia neonatorum, or that neonatal conjunctivitis. It's going to be a redness. There'll be swelling. They can have eyelid edema also, and a purulent discharge. The most common cause of neonatal conjunctivitis, that sounds like the lead into a question, in the first 24 hours of life is going to be silver nitrate. When babies are born, one of two things are done to them to help prevent the Neisseria gonorrhea or gonococcal ophthalmia neonatorum. And what they do is they will put either erythromycin ointment in the eye or silver nitrate drops in the eye. And the silver nitrate will cause a chemical conjunctivitis. So think of the first 24 hours of life, a baby with conjunctivitis, think of chemical conjunctivitis. Because we treat these babies for gonococcal ophthalmia, the most common infectious cause of conjunctivitis in the neonate, that sounds like another test question, is going to be chlamydia. The erythromycin ointment does not prevent chlamydia conjunctivitis. It does prevent gonococcal conjunctivitis. The diagnosis is usually made with a gram stain and a culture, and the treatment of chemical conjunctivitis, you will have negative findings there, and the treatment is just basically leaving it alone. You can irrigate a little bit, but leave it alone. If you have chlamydia conjunctivitis, the treatment is going to be erythromycin, enterally, not topically. Again, it doesn't prevent it from happening, but it is the treatment if you give it enterally. And if you have gonorrhea conjunctivitis, then you will treat that with ceftriaxone. Part of your differential diagnosis is dacryostenosis, and I'll have a picture for you in a second. And that is a nasolacrimal duct obstruction. And so you will see some swelling on the nasal side of the face by the eye, and you will have some sometimes purulent discharge. And so it's hard to say, is this conjunctivitis or dacryostenosis? But with conjunctivitis, you'll have more of the redness of the eye. Here's a child with chlamydia conjunctivitis, so you would have to do a gram stain and look at it. This is a child that would be benefited from erythromycin treatment, not the ointment, but enterally. Here's a child with dacryostenosis, and you can see many times it is unilateral, and you see this swelling right here. If you actually push on that, some purulent discharge can actually come back up the nasolacrimal duct and out towards the eye. But you notice that here the conjunctiva are clear and not bloodshot. Treatment here is massaging 3 to 4 times a day. Once the baby reaches 1 year of age, if this is still present and is not resolved, then referral to the ophthalmologist would be indicated, and typically they would just take a small probe and open up that tear duct. A lot of people talk about pink eye. We really don't like to call it pink eye. We'll call it the red eye, and there are a lot of different things that can cause red eye or conjunctivitis. They present with tearing. They can have conjunctival injection or even a subconjunctival hemorrhage at times, and they can have lid edema and eye discharge. It's hard to tell the difference sometimes between bacterial and viral conjunctivitis. Bacterial causes of conjunctivitis include strep pneumonia, H. flu, and Staph aureus. And the treatment will be local antibiotics, typically some broad spectrum antibiotics to cover the most common causes. Here's a patient with bacterial conjunctivitis and looks like a subconjunctival hemorrhage also. Really, really irritated conjunctiva. And also you can see up here redness of the eyelid. Viral conjunctivitis many times is bilateral, Bacterial can become bilateral just because they can seed the other eye when they are rubbing. Viral conjunctivitis tends to be a watery discharge, not as purulent as the bacterial conjunctivitis, and many times is associated with upper respiratory infections. So look for URI symptoms preceding or associated with this eye discharge and some redness, and then you should be thinking it's more of a viral cause. Adenovirus and enterovirus are very common causes. We talk about adenovirus causing a conjunctivitis and sore throat, so a pharyngoconjunctivitis. Think of adenovirus. Other causes of conjunctivitis include allergies. We've talked about seasonal allergic rhinitis, and sometimes they can have conjunctivitis associated with it, and certainly chemicals can cause conjunctivitis. A foreign body, typically if the patient complains of eye pain, if they have a red eye and it is painful, then don't think of conjunctivitis as the cause. You should be thinking of corneal disease when they are complaining of pain and photophobia in particular, and that could be a corneal abrasion or a foreign body. That can cause a red eye. Also, uveitis can cause a red eye, and the orbital periorbital cellulitis can cause redness of the eye, and we'll discuss them shortly. Retinoblastoma, we kind of alluded to it earlier when we talked about leukocoria. Retinoblastoma is the most common primary malignant tumor of the eyeball. It is a recessive gene, therefore family members should be screened. So a question might be that you have a patient with retinoblastoma, what else should you do? And the possible of the answers is screen family members because it can run in families. Usually it's diagnosed a little bit later, 15 to 18 months to 25 months. That's why you need to look at red reflexes throughout, not just at birth, but whenever the patient comes in for a routine visit, you should be looking in the eyes and looking for red reflexes versus white reflexes. Sometimes it will be discovered at birth with leukocoria. Certainly the leukocoria is the first thing that you'll notice. Later on, the patient may have strabismus because since it's a deprivational mechanism, they're not really seeing out of that eye, and so they start to have strabismus and possibly amblyopia. And it will be seen as a white mass. The diagnosis of retinoblastoma you're going to make on CT scan. So if they ask you a patient that has a white reflex in the eye, what's your next step? Get a CT scan of the head, and that will make your diagnosis. Papilledema, when you're examining the eye, is indicative or reflective of increased intracranial pressure. And you will see a blurring of the disc margin. It kind of is coming out towards you when you're looking in the eye. Normally it's flat, and the disc will be coming out towards you, reflecting the increased intracranial pressure. They always say that the eyes are the window to the brain, so you can actually start considering increased intracranial pressure if you see papilledema. This is a later sign of increased intracranial pressure. Many times you will have other signs and symptoms such as the headaches and vomiting, things like that. If it's a slow, gradual increase in intracranial pressure, you may not have too many of those signs and symptoms, and you will see papilledema. It can cause optic nerve damage if it's sustained for a long period of time, so that does present an emergency. Causes of papilledema include intracranial tumors, and that's one of the first things we'll think of in a child is that they have an intracranial tumor causing the increased intracranial pressure, which is causing the papilledema. Certainly also hydrocephalus, so basically anything that increases intracranial pressure is part of your differential diagnosis for causing the papilledema. We will see that sometimes after trauma and again subsequent cerebral edema, certainly the last one, number 8, pseudotumor cerebri is a part of a consideration of your differential. These are patients that have many times complain of headaches and visual disturbances, and they have papilledema on their exam, but they have a normal CT scan. That's why it's called pseudotumor cerebri. They act like they have a tumor. They do have increased intracranial pressure. If you do a lumbar puncture and measure the pressure, it is increased, but there's no real cause like obstruction or tumor or infection for it. That's why they call it pseudotumor cerebri. Once you see papilledema, you need to do a CT scan to make sure that there isn't a mass, and then you can check intracranial pressures by doing a lumbar puncture and measuring the pressures. Glaucoma is not commonly seen in children. There is a congenital glaucoma. This is can cause damage to the optic nerve because there's increased pressure in the eye. So you can have damage to the optic nerve because of increased pressure in the brain, but you can have damage to the optic nerve because of the pressure in the eye working the other way. And again, in children or in infants, the congenital glaucomas, these are very, very painful. So you're going to look for a very, very, very fussy child, and sometimes, and you will see what we call ophthalmos. That eye will be actually protruding, and it'll be somewhat larger than the other eye. It can be a result of ocular or systemic disease. You have a listing there of different causes such as trauma or hemorrhage that can cause glaucoma, or a tumor can also increase the pressure in the eyeball itself. And there are some syndromes associated with glaucoma. And that is why with certain syndromes that there's a higher risk of glaucoma, regular routine ophthalmologic follow-up is recommended. Again, patients can have excessive tearing, just like if you do with conjunctivitis. They can have photophobia and pain. So again, pay attention to painful eyes. If the eyes are runny and red and not painful, not a big deal. If they are painful, think of corneal disease or possibly glaucoma. And the treatment will be surgical to relieve the pressure.